That was a reminder for my husband to take his pill. He set that reminder on Alexa. So I'm sorry it interrupted, but in a way that's kind of cool. I'm going to have to call him since he's at work, so. But there goes another way to help somebody with their medicines. If they have an Alexa that loves them like Alexa loves my husband, they're in great shape. We're talking now about the caution zone. So the caution zone, I was going to tell you, the age group of our patients, 60, 70, 80, and 90 years old, you know the truth about those dear ones? They don't want to bother anybody. They don't want to come to the hospital. Most people don't. As many of you know, COVID has scared people. They don't want to come to the hospital. They're afraid of COVID. The hospital is probably one of the safest places in the world you could ever be as far as COVID. But these people want to wait. They don't like to call. They don't like to bother the doctor. And so when you get to the caution zone, you can use some of those phrases. I find it works out very, very well, especially if you have a husband in the bed or in the chair. Either way, husband or wife, man or woman, significant other, you're going to find there's a bit of stubbornness when it comes to being able to self-assess. They don't want to come. So when I get to the caution zone, I let them know, if you were crossing the highway and it was a yellow light, wouldn't you watch both ways? Wouldn't you take a little moment, make sure no one's going to T-bone you, that you're not going to get into trouble, that someone's not going to run a light? And usually they can all relate to that. Because you see, you have to realize the symptoms you just told me you have, once they start creeping up on you, once you're 2 to 3 pounds up in 24 hours, once you're weighing and you're seeing this gradual increase of weight or discomfort or swelling in the body or difficulty breathing, whichever symptom belongs to that patient, you have to tell them earlier is better. You cannot wait. And I tell them that. You know what they usually say? I waited too long. I know you're right. I had one man who said, I had an appointment next month. Oh, golly, you're up 20 pounds and you're going to wait till next month. You can't wait. And the quicker you get in and the quicker we get excess fluid off of you, the quicker you get home. And so they begin to realize, what do I want you to do? And the yellow zone is very specific. It's so good. If you start having that little hacky cough that you know isn't pneumonia, it's fluid. If you begin to have a little bit shortness of breath, just doing something small, walking to the kitchen. If you have some increased swelling in your feet, your legs, your tummy, your ankles, you've already been in the red. You don't want to go there again. When it's gradually creeping up on you, and again, the weight, you tell them that again. And you also have an opportunity to tell them exactly how to do their weight. I want you to get up in the morning. I want you to empty your bladder. I want you to go to the bathroom before you eat or drink with the same thing on or off, because we're not going to be there to see you. Get on the scale, write it on a calendar, a notebook, a piece of paper, a weight sheet. We've got them. We can give them some. But then I want you to track it. I want you to see how much weight have you packed on over what period of time. I was very proud of a lady. She was so proud of herself. She came back in after she had been in probably about maybe 2 or 3 weeks. And she was so proud. She brought her notebook with her. Donna, look at this. I've got my blood pressure. I've got my blood sugar. I got my weight. She's so proud. And I'm looking at that. Oh, you did so good. But look here. On this day and this day, how much weight did you gain right there in those 2 days? 6 pounds. She could do math. Oh, and you didn't call? Oh, no. And then look here, you're even higher now, you're 8 pounds. I see that. They have to realize that it's okay to call the doctor. It's okay. It's okay to call the nurse practitioner. It's okay. And this little yellow zone tells you what to tell them to expect. A change in their medications, most likely an additional diuretic. The doctors might say to them, take an extra diuretic today, take an extra diuretic tomorrow. We'll get some labs drawn. We'll want to see you. And here's something I want you to think about. If they're taking extra diuretics to get fluid off at home and they're on certain amount for the month, they may run out at the end of the month. Because I just had a woman have that happen. I took extra, and now I'm in the hospital because I ran out of my diuretic. Well, that makes sense. So what do we need? Another prescription for PRN? Or a higher dose of pills so they can split it? But we need to be cognizant to help these dear people, because when they're trying to manage by themselves, that's part of what some of the doctors will let them know. I want you to take an extra pill if your weight is up. And so here we go. They need to connect with their physician. And this is, of course, the self-check plan, American Heart Association, and you can get on this website. It's excellent, Rise Above Heart Failure. And there is wonderful tools for you. There's also information on every cause and everything that you could imagine, from hypertension to atrial fibrillation to TAVR, you name it, we've got it. And we've got it in the folders. I will tell you about these folders. These folders are meant to be for you to use to fill however your group of patients require it. And I can give you some examples. If you're on a heart unit where you do an awful lot of coronary artery disease and stenting, there is a folder for that. And in this folder, you've got a Cardiosmart, what is coronary artery disease? And again, very quick, explains what it is. And then the American Heart Association has answers by the heart. What is a stent? And that is lovely because it's just a couple pages, and it also gives the patients websites for networking. You know that American Heart Association's motto is "Life is Why." So, coronary artery disease and stents. Perhaps you are on a unit where you put in an awful lot of pacemakers and defibrillators. Again, answers by the heart. Beautiful, beautiful pictures, beautiful explanations. If you're not comfortable, these are from the dear ones who write the guidelines. And so what are they going to do? They're going to be totally updated all the time. And they use a question format. Why would I need one? How does it work? What is a pacemaker? How do I live with it? Can I use a cell phone? Things that if the patient just asked you, you may not know the answer. But that's why they call it Answers by the Heart, because the American Heart Association knows. Oh, here's a wonderful one I love. Now, this is Rise Above Heart Failure, your ejection fraction explained. And unless you truly have a good grasp on what is preserved ejection fraction, I would say only use this if someone has an echo where the ejection fraction is reduced, because it can be confusing if you don't truly understand those two terms. And let me explain that for you, because I didn't yet. They used in the infographic of what is heart failure, they used systolic and diastolic heart failure. Another term for that is heart failure with reduced ejection fraction. That's your systolic. And then they have heart failure with preserved ejection fraction. That's the thick, powerful pump that fails to meet the body's needs because it doesn't have enough volume. That is preserved ejection fraction. So when you're looking at an echo and you're looking at the ejection fraction, their ejection fraction falls in the normal range. How you want to explain this is all explained for you. What is your ejection fraction anyway? It's a fraction. It is what? The amount of blood your heart pumps out over what you have available in the heart chamber. Multiply it by 100, get a percent, and then you have to make this point for patients, because sometimes the docs will come in and go, your heart is pumping at 25%. What do they think? They think your heart pumps 100% of the blood out with every squeeze. Not so. It is a circulating fluid-filled pump. It will always have blood in the pump. The pump itself is going to squeeze out 50 to 70% of the volume with every contraction. So 50 to 70% is normal. And this is so good because it tells you borderline is 41 to 49%. And it tells you with a little icon here that you might feel a little bit of something when you're out walking the dog and exerting yourself. And then you look at the guy down below here, and what's he doing? Reduced ejection fraction, only 40% is pumped out or less. And you can have symptoms even when you're sitting. So if you use this infograph for someone, and in the chart, guys, you're going to see this. Capital H, capital F, little r, capital EF. Heart failure, reduced ejection fraction. Capital H, capital F, little p, capital E, capital F. Heart failure, preserved ejection fraction. Greatest thing, it does tell you about preserved under here, but still, unless you can really explain that well to your patients, this may be something that you only want to give to someone who's got reduced. But if you feel comfortable, use it because it's got that information here. You can have heart failure with a normal ejection fraction. It tells you that. But the greatest piece here is this one right here. With proper care and treatment, many patients are able to improve their ejection fraction and live a longer and healthier life. Talk with your healthcare provider about your options. And I've seen it. And I want you to know that sometimes physicians don't realize there's something called heart failure improved ejection fraction. Remember when I said heart failure is not a cold? It's very similar to diabetes. If you have diabetes, you're never going to be someone who doesn't have diabetes. You can control your diabetes. Your numbers can look good all the time. Does that mean you're not a diabetic? No. You can have heart failure with an ejection fraction of 25%, and with the right medicines and the right life and the quality, you can improve it. You can get up to 50. When you're 50% and a doc says to your patient, you don't have heart failure, you don't need a diuretic. Now maybe he didn't investigate the chart very well, because 6 months ago, that patient was a reduced ejection fraction with less than 50, with 40 to 45%. He was a reduced ejection fraction heart failure patient. And so when people just look at numbers, don't look at the patient, don't look at the other symptoms, you could say, well, that's normal, but maybe we should look at your history. Normal since when? You know, what were you when you had your echoes a couple years ago? And you will see we are doing very, very well with improving, because we want to improve the pump. We improve the pump, we improve the ability and the quality of that pump through the medicines that we have that are excellent. for them watching their salt, watching their fluids, taking their weights, doing what they need to do to manage their heart failure. We want them to improve. And when they improve, we got to be proud. Got to be proud of them because they've learned how to manage. There is a difference between management and maintenance. You maintain your car, you wash it, you do whatever. But management of heart failure, you've got to be able to identify what's wrong with it. And it's the same with you. You're going to manage your car. When it starts knocking and making a noise that, oh gee, you know you got to do something. You got to act. So hopefully this has been helpful. Let me grab a couple of these others so that you can see what we've got. And again, you can get on these websites. There's a folder available to you that you can pull down whichever ones match your patient population where you work. Here is valve, aortic stenosis, and TAVR. Excellent. And again, it's a mix of your Cardiosmarts and also American Heart. And you can do that with whichever area you work in. I will tell you this, atrial fibrillation, I'd like to make a point with that. If you have someone with atrial fibrillation, the craziest piece about it is the fact that the symptoms are very similar to heart failure. And there are 3 different types. One patient can have some, it's called paroxysmal. It comes and goes. I jump into normal sinus, I jump into atrial fib. It just comes and goes. Paroxysmal, intermittent. And then you can have persistent, and then you can have permanent. And you know all the things that we do. But the most important thing I want you to know is that your symptoms of fatigue and shortness of breath and dizzy lightheadedness, all these things, some people feel palpitations and chest pain and some people don't. And the people that feel nothing, when the heart's going at 150, oh my goodness, it's going to throw you into heart failure. So taking care and recognizing atrial fibrillation is important as well. It is one of the it's an irregular rhythm, but it is the most common arrhythmia that we have in the world. And oftentimes you don't have a reason for it. You can't blame anything for that. We also have in our packets that we provided for you, stop smoking, sleep apnea, and high blood pressure. And again, that's the same. We have wonderful infographics that tell you what's normal. And again, your lifestyle changes are right there. Boom, boom, boom. Yeah, so easy. Oh, physical exercise and activity. And that's another thing that I need you to know for your heart failure patients is extremely important. So hopefully this is something to get you on your feet as far as your education. We will be doing something. We have beautiful magnets, and our magnets are just like the heart failure zones, just like the Rise Above Heart Failure self-check plan. It's the very same. Only this could go in the refrigerator, and they can actually put the doctor's name and phone number on it, and they can put this, if it sticks on the refrigerator, which I hope it does, green zone, yellow zone, red zone. And so what we're doing is we're going to put this magnet on the door frames of the patient rooms to signify daily standing weight. And I'd like to say something about that. We have to be very careful when we're doing weights that somebody doesn't have their robe on or 5 gowns on or something that's going to make it inaccurate, because that weight is going to tell us a lot. We're going to monitor that the whole time. So this will be on the door frame of our rooms. Now, it'll signify we need standing weight. Great thing about it, we get to give this to the patient when they go home. And that is going to be a wonderful thing. The other standardized education that we have decided upon is Living Well with Heart Failure. It's a Crames book. It is the book that patients would get if they went to cardiac rehab. Now, it's beautiful. It's much more in depth for people who absolutely love to read. Now, if somebody doesn't love to read, You might have a little bit of a problem. It may not be the patient that you're giving it to. It may be the daughter. It may be a spouse. It may be a friend that helps them. One of the greatest things in this book, you have an excellent section on sodium. And it tells you about how to help these people when they're getting into a low sodium diet. You could actually think of it this way. Always go on the outskirts of the grocery store. If you're going to go in the inner city, you got to be careful. You got to look at your labels, because you know what? There could be criminals in there. Not really, but you know what I'm saying. You might be tempted to buy something very salty when you're going through the boxes and the macaroni and cheese and the rice and sauce. And so these are just some of the things that we have available for the patient. And again, not everyone is eligible for cardiac rehab. So when we're giving them contents and things and talking about sodium and fluid restrictions, these are wonderful, wonderful resources for them. Some have them. You don't need to give a book to someone who has 3 in their closet. And I had a gentleman who told me that the other day, and I said, good, I'm glad you got it. I want you to get it out. Give the other 2 to your daughter and your wife and whoever is going to help take care of you. They don't need resources that they already have. They don't need resources that they're not going to use. And if they're not able to read and cannot see, we've got to be creative and find some other things for them. Also, in your folder that we've got for you, there are online, beautiful, beautiful online resources. And I have a Deaconess resource sheet as well that goes over all the important things that we do here at Deaconess. The medication therapy management, if you didn't know it, MTM are marvelous pharmacists. They will help our patients understand their meds. They will track things for them. They will help them with smoking cessation, which I've been using them quite a lot with that, trying to get people to stop smoking. Also realize we have a couple different types of patients. They are adult learners. When you talk to people, it's often very kind to ask them what they've done with their life. What kind of work have you done? Excellent question to ask. And you will find skill sets when you ask that. Maybe the patient has owned a restaurant and has dealt with food service and read labels. Had one patient, I was so impressed. He had weighed 400 pounds. He'd lost 200. Well, is that a man of determination? You got that. While you are telling them these things, you have to realize they have to want to make the changes in their lives. We can want that, but we want them to want that health-related quality of life. And we're there for them to help provide whatever is needed. You will have a high group of patients, I am sure probably a higher number than you think, who are technologically savvy. And when you give them the online, you also can show them different resources, for example, cookbooks. There are free cookbooks that they can download if they're still cooking. You'll have some people who are eating out the whole time because they're widows. You can get online and pull down that restaurant's nutritional content, highlight the sodium content of the food. I did that for a dear man who goes to a buffet, and you would have thought I gave him gold because he really was trying to eat correctly. And so there's things that you have to do. You have to match what we have available to what these dear people are living. And so you kind of have to know a little bit about their life and their support system, so you know that whatever it is that we're going to give them is the right tool. Just like the story with the lady in the scale and she couldn't see. I will tell you, we have some people who are very heavy. They cannot stand on a scale. So I learned this from a patient. He said when he was signing up for disability, what they did, they took 2 scales because his legs were quite broad and he wasn't able to stand on a small scale and put his feet together. So they had a scale for his right foot and one for his left, and he got on both of them and was very well balanced, and they took those two numbers and added them together. I would never have thought of that. I would have thought, oh boy, you're going to need a standing scale with handles. And no, there's a wonderful idea from our patients. I hope this has helped you. If you have any questions, you know, you can always call me. I'm sure we're going to have a good time. Our patients who have heart failure are some of the kindest, sweetest people you'll ever want to know. And some have had a hard time in life and may not change behaviors. We'll do the best we can for them, as we will for all, because that's Deaconess model, all for you. So I hope this has been helpful, and I thank you for your time. If you have any other questions or you need anything, please feel free to call me. Thank you.